one time we had somebody come into the emergency department. A C-section was called and she was asleep with baby out within, like, you're talking like minutes.
Oh my goodness.
Yeah, it's very quick sometimes. Then if they're going asleep though, essentially what you do is you switch off their consciousness.
Yeah.
You know, you render them unconscious. And it is essentially a medically induced coma.
And I was reading up about anaesthetists and type of personalities that you have, and it's definitely type A.
Oh yeah. Yeah. Like, we are absolutely kind of caffeine addicted.
Attention to detail.
Yeah, attention to detail. It kind of like, it's always, the analogy is always drawn toward kind of flying planes and that kind of stuff. Check, 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 check. Kind of nearly like, not OCD in like a horrible decompensating way, but we are nerds. I remember seeing a meme and it's like, you know, we talk about the anaesthetist being like over caffeinated, under caffeinated, but never appropriately caffeinated kind of thing. And, you know, the loads of anaesthetists like love cycling, long distance cycling, and it's like nearly like a cliche.
Anne, it is wonderful to have you here today. She's laughing already. We've been having a crack since before we started.
Yeah.
Anne, you are an anaesthetist.
Yep.
And I thought it'd be really interesting to get you on to talk about your work.
But hopefully it is.
I know, yeah. Everyone's switching off now.
Yeah,
oh God,
exactly.
we don't want to talk about
She just puts people to sleep. I'm asleep already.
I know. Oh, that's one of the jokes, isn't it, about anaesthetists? They just put people to sleep.
Apart from their own children.
I know. I can imagine. But also there's like pain management. There's all kinds of things that go with your job. Risk management, all that. So first and foremost, what does an anaesthetist do and how do you do it?
Okay. So kind of the anaesthetic job umbrella can be quite broad. So strictly speaking, you render people insensate to the surgery so that they're not in pain during surgery, okay? And that can be done a variety of different ways. The other thing that we do, though, as part of our training is that we look after acutely unwell people, so people who would be going to high dependency or intensive care. We're part of trauma management teams down in the emergency department. When people go to the resus bay, if they need admission to high dependency or ICU, we're down there in the emergency department as well. And as part of our training, we do some acute pain management, and we do some training in chronic pain in that there's an awareness there of it, but that requires further specialization, as does intensive care. If you were just going to be an intensivist primarily, you'd go on and do further exams and all of that. So it's quite broad.
Yeah, it is. And I was reading up about anaesthetists and the type of personalities that you have, and it's definitely type A.
Oh yeah. Yeah. Like, we are absolutely kind of caffeine addicted.
Attention to detail.
Yeah, attention to detail. It kind of like, it's always, the analogy is always drawn toward kind of flying planes and that kind of stuff. Check, 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 check. Kind of nearly like, not OCD in like a horrible decompensating way, but in terms of consistent checks, pattern recognition. Like, essentially what we do is applied physiology, applied pharmacology, pattern recognition.
Okay.
And kind of acute life support. That's basically what anaesthetics is.
The anaesthetics part of my training when I was in pharmacy school, I loved it because I loved the various stages of it, you know, when you're going from one stage to the other. So we can talk a little bit about that. But what drew you to anaesthetics? And you're in the rotunda, so obviously working with pregnant women and deliveries, etc.
Yeah, and I'm in the mater as well.
Okay.
So basically, I finished medical school, and people actually don't realise that we're doctors first. So you do general medical degree, and then you do your 1 year of kind of medicine and surgery intern year, and that's your first post-college clinical doctor job. You are a doctor at that stage, but you're very junior. And then you can either go into medicine, surgery, blah, blah, blah. So a lot of people go straight into anaesthetics at that point in time. And I did 2 years of general medicine first, and I did some general medical postgraduate exams. And I was during that time I realised that I really only liked the hyperacute stuff. I did like the rest of it, but I really loved that hyperacute kind of
adrenaline junkie stuff then, yeah?
Yeah, the edge of your seat stuff.
Okay.
Yeah. So then changed to anesthetics and did my anesthetic training then. And then even within anesthetics, there's subspecialties. So in Ireland, in the UK, and a lot of Europe, the intensive care doctors, the vast majority of them go through anesthesia training first. And we would do a lot of intensive care management as part of our anesthetic training. Because you get those critically sick patients who need to go for surgery, you know, and that collegial kind of cross-pollination of training is actually really, really useful. Okay. Really useful in kind of our acute services. Okay.
Yeah.
Within the hospital. So there's that obstetric anesthesia, which is what I primarily do. And that's kind of like Marmite. So people either really love it or really don't like it.
Okay. As in
anaesthetist. Okay. When you're training.
Okay.
So I loved it. I just loved it.
Okay.
And then there's cardiac anesthesia, and then there's like lots of all subspecialties.
And then anaesthetists were very much called upon during COVID, weren't they? In the acute sense, where people needed to be put into an induced coma when they were very, very sick. Yeah. Did you work in those circumstances?
Partly, yeah. So during COVID in Ireland, so what it kind of comes down to is there was a lot of redeployment in that stage away from theatre and toward the ICUs, okay, because they were becoming extremely busy. Yeah, sorry about that. Yeah, sorry. That was Faisal probably just leaving school. But sorry about that. But so a lot of trainees were redeployed. It was much worse in the NHS, I think. They were much harder hit in terms of their hospital COVID numbers, and they're needing to use theatres and kind of the anaesthetic machines as ventilators and that kind of stuff. We didn't quite hit that here, thank God. But we, in terms of the pregnant patients, different phases of COVID had different kind of effects on pregnant patients in terms of susceptibility and severity of illness and stuff. So, you know, there was decisions being made about when is the right time to intervene, you know? Yeah. In terms of delivery and things like that. And then you'd be trying to keep the mother as well as possible during that. Because she was now with COVID quite sick and going through surgery, you know? So it was
edge of your seat stuff.
It was COVID.
Yeah, absolutely. Oh my goodness.
It was, it's just, you know, none of these things, no decision is made in isolation. You know, there's a multidisciplinary team involved. So it's not like we were making the call. It was being made across a number of specialties. Yeah. You know?
And one thing you said there was that people often don't think that you're doctors. And that is actually very true. When I put the feelers out, people don't think that you're doctors. Yeah. But also they think that there's a rumour that goes around that you don't actually like patients either, because you just that's why you just want to keep putting them to sleep. You don't you don't have to have the banter with them. But actually, that's actually quite untrue, because I've had a couple of operations myself, and the anaesthetist, I've always fallen asleep having the banter with the anaesthetist, because that's what you try to do. You are chatting away to them, and you are chatting away to them, and then you're putting them to sleep really, really quickly. Isn't that it?
Yeah, like I think it's really important to have a rapport with a patient that you're putting asleep, that they know that you know what you're doing, and that you're safeguarding them, and they need to go asleep knowing that. Yeah. So it's a short period of time that you spend with somebody before you, I'm choosing my words carefully because I don't want to freak people out. Yeah. before they go asleep, and you're their voice, and you're their safeguard, and you're the person who's keeping them safe through all of these interventions, you know? So yeah, it's a very quick rapport that you need to build with somebody.
So tell me and explain to any of our listeners what happens when you put someone under anaesthesia. You're looking at me going, do I really have to tell?
No, sure, I talk about this all the time.
And
I talk about this with people all the time, because, you know, people come in and they kind of say, I'm so silly, I don't know why I'm so nervous. And I'm like, oh, of course you're nervous, you know? And they go, no, I'm not nervous about the surgery, I'm nervous about the anaesthetic. And I said, of course you're nervous about the anaesthetic, you know? It's great unknown, you know? So, the first thing with anaesthetics is that, like, especially if it's a general anaesthetic, you're taking that person's agency away from them. You know, they're trusting everybody in the room to safeguard their well-being and handing over control. So of course, everyone is going to be nervous about that. And I think that's why you have to have that rapport with somebody quite quickly. And then with anesthesia, so you have to render them like insensate to the surgical intervention so that they don't feel the pain of that surgical intervention, okay? It doesn't always have to be a general anesthetic. It could be a regional anesthetic where essentially the sensation to the area that's been operated on is just put asleep, but the person is awake, or it could be lightly sedated, okay? If somebody is going to, so you do that with local anesthetics to the nerve, like a dental block, but on an industrial scale, essentially. Then if they're going asleep, though, essentially what you do is you switch off their consciousness. Yeah. You know, you render them unconscious. And it is essentially a medically induced coma, you know. So people talk about, oh, I'm nervous about going to sleep, but they're nervous because they're not going asleep. You know, it's very different. They're going temporarily unconscious to facilitate a very painful procedure that is for their well-being. Yeah. You know. And
what do you use to make them unconscious?
So there's lots of anesthetic agents, loads and loads, different kinds.
What's your favourite?
Probably propofol.
I knew you were going to say that.
Yeah. Well, it's for lots of different reasons, but it's essentially they work in a couple of different ways, but they either kind of inhibit the neurons that help you stay conscious, or they facilitate the inhibitory neurons to switch off the other ones that help you stay conscious. And like your consciousness is way back in, like that switch on, that reticular activating system is way back at the back of your brain in a very, very kind of primitive region, you know? Yeah. And all the, you know, critical thought processes are up here, but it literally just switches them off, you know? Okay. So that's essentially what we do.
And then
the other aspects of anesthesia are separate to that. Okay. You know? You can put somebody unconscious, but you don't necessarily have to operate on them. You know, if somebody's been operated on, you render them insensate, but they also have to be immobile in terms of this anesthesia. You know, there's no point in putting somebody facilitating surgery if then they're trying to operate in the arm and the arm is around the place. Sorry for hitting the mic.
Does that happen? The arm be flailing around? Someone did message in saying she woke up from anesthesia. So that's arms flailing. Yeah. So awareness under anesthesia is different. So with anesthesia, you've got insensate or unconscious, and you've got lack of mobility to facilitate surgery. And those things will be dictated by the kind of surgery you're having done. Okay. And then you've got pain relief, anti-nausea and vomiting components. And that's kind of your perioperative comfort care. Okay. Yeah. If you are going asleep for surgery, there is a phenomenon that everybody is always afraid of. People are afraid of two things, either A, not waking up, or B, waking up. Yeah. Okay. Yeah. And both are very reasonable fears. Yeah. So with accidental awareness under general anesthesia, in that situation, a couple of things have to be in place for that to happen. Okay. And as I talk about it, I'm aware of people like freaking out as they listen. But they're listening because they're interested.
Yeah. So generally we put somebody asleep in certain circumstances in order to facilitate surgery, okay, or to facilitate control of breathing, okay. A neuromuscular blocker will be given as well. Okay, and I see you looking at me going, here we go.
I love this. I love this.
Really?
Yeah, I just love talking about all this.
Okay, so in that situation, what it does is it essentially temporarily stops your muscles from working, okay? And that's really useful to the surgeons because they need to be able to safely move past those, like say for abdominal surgery, so move past your abdominal wall muscles and into your viscera to operate on them and do whatever needs to be done, take out a tumor or whatever, okay?
So it makes them slack.
It makes them slack. It just makes surgery safer. Okay. In that situation as well, we would, or for airway cases or something like that, where you need to control breathing and put somebody on a ventilator, you would put down an endotracheal tube and put them on a ventilator. And they need, for the most cases, not always, but most cases, you'd administer a neuromuscular blocker in that situation as well.
Do most surgeries need a neuromuscular blocker that stops breathing?
No.
Okay.
It depends.
Okay.
So most people will, on induction of general anesthesia, they'll temporarily stop breathing anyway, okay, because it's a side effect of the medications used to render you unconscious. But they can actually start breathing after that again, unless they get administered a neuromuscular blocker.
Okay.
So for like a lot of cases that are very superficial surgeries, we don't actually give those. Give neuromuscular blockers, and they would have a lower incidence of that accidental awareness under general anesthetic, because if somebody was light, they'd actually move before they'd even be aware of something.
Okay. But you know the way, so I remember learning about it, if someone was administered a neuromuscular blocker, right, and they can't move, but the anesthesia wears off and they can't even, they can't move, but they can hear what's going on and they can feel what's going on. Has that, like, is that very rare? Does it ever happen? Or is that just a boogeyman story?
1 in 20,000.
Okay.
Is the most recent data. Now, again, I would be careful. So the NAP5 is a national audit project that between Ireland and the UK, and they looked at that, okay? Because it's a tricky thing to study. You know, some people think, oh, I've woken up under anesthesia, but really they just remember waking up in recovery, maybe as a little airway support was coming out or something like that. And it's not related to the surgery. It wasn't during the surgery.
Okay.
Because, you know, people wake up and have things done and then they go back asleep and they think, was that actually during the surgery or not? I heard people talking. Now, there are some cases of absolutely explicit recall, you know, where people can remember very specific things, but they're more uncommon.
Okay.
You know, and it's in very specific situations that it would be regarded as higher risk, where people have like really unstable blood pressure and they can't get the standard dose of medications, or things happen very, very rapidly to facilitate surgery, and there's a little gap in terms of their anesthetic cover or something, you know. Now there's monitors available that look at your brain waves and give you a numeric reading essentially of how sleepy those brain waves look.
Okay.
You know, and it's comforting to have them on board to a degree, but I think that the response time with those, you can be like a smoothing effect of maybe 45 seconds. So it's not quite as responsive as instantaneous. And I think having an anaesthetist who's paying good attention and, you know, understands the dynamics of what's happening in terms of you and gaps and surgical stimulus and all those. It's where the art form comes in after the science, if you know what I mean.
So you can't take your eye off the ball at all.
Like, but there's always an anaesthetist present when you're under anesthesia. Always.
And you're not sitting there with your arms folded, kind of just...
Oh, we are if you're doing it right, yeah.
Okay. Okay.
So after you've put somebody asleep and you've controlled their airway, their breathing, their oxygenation, their circulation, you've given support, you're managing their blood pressure, you're watching their heart rate, you're literally just watching the beeps.
Okay.
And you're watching pattern recognition, and you're watching a series of monitors. And that's the autopilot bit, but you're not really on autopilot.
Yeah.
So you're checking blood pressures every minute to 5 minutes. You're watching breathing patterns. You're watching your ventilator settings. You're watching your anesthetic administrations. You're watching your IVs. You're giving painkillers. You're giving anti-nausea.
You're orchestrating the entire process.
And you're watching the surgery. You're watching for bleeding. You're just there the whole time, yeah. And it's all pattern recognition. Yeah. And like somebody could come in and chat with me and we're all still looking at the screens. And if you look away and the beep changes, you literally, the anesthetic heads all just swivel to the screen. Okay. And like you can see, you know, when there's a change in heart rate before it reads on the monitor, because you hear the interval between the beats and you're so attuned to that interval. Yeah. It's funny, like.
It's an art, really, isn't it?
It's
an art / science.
It's a science, but like it's like we love what we do, you know, that kind of way.
No, it seems so.
We find it very interesting because we're extreme nerds, like.
You don't look like a nerd. What does a nerd look like?
We are nerds. I remember seeing a meme and it's like, you know, we talk about the anaesthetist being like over caffeinated, under caffeinated, but never appropriately caffeinated kind of thing. And, you know, loads of anaesthetists like love cycling, long distance cycling, and it's like nearly like a cliche, and then the books and the applied physiology and the crosswords and the Sudoku is always a joke, but not really. You don't really have time for it. But yeah, we are absolute nerds. It's all physics and pharmacology and physiology and dynamic changes and debates over pressure and flow and really silly, nerdy things.
And do people ever say anything silly or give away all their secrets while they're going under or coming out of?
Say silly things sometimes, but not in a bad way. They're generally just very, very nice people.
Yeah. Really, really chilled out.
Yeah. Pretty much.
I remember I picked up someone recently from the hospital who was under anaesthetic, and they wouldn't generally be the most easygoing person. And when
so chill.
When they were like, oh my God, I feel so good. This is brilliant.
I know.
So it's funny to hear it.
Yeah.
And, the person just would not tolerate that normally, isn't it?
Well, that's a good anaesthetic.
Yeah.
100%.
Yeah.
Yeah. So it depends. The ideal would be that you get somebody in and they're happy and confident going for whatever kind of anesthetic they're getting. And then when they're in the recovery period after the surgery, that they're feeling really good, and it doesn't always work that way, but that's the aim, that they feel good and they understand in terms of their recovery period. Like obviously surgery is not always 100% pain-free. There's a recovery period for everything, but that they kind of understand coming out of it how to optimize the recovery and that they have their own agency with it, and they're co-opted into kind of their own recovery as well, and they understand the milestones and they can feel confident in that and come out of it with pain control.
Anne actually is... Now we're going to say it properly. Afif is lucky enough to be Anne's husband.
Thank you.
The gentleman that I did the podcast with on breastfeeding is lucky enough to be this woman's husband. We'll get into that later. I said we're going to roast you, Afif. We're going to roast you.
He deserves it.
Can we speak a little bit about what you do in the rotunda? Because obviously that's very different to put in people. Well, not very different, but you don't usually put people under general anaesthetic.
Most of the time not.
Yeah. So tell me about that, how you got into it and what you love about it.
Oh, this is where I'd get a bit like, I actually just love our patients. I just think they're brilliant. Yeah. Like, I think it's such a privilege to be there on some of the most important days in these people's lives.
I know.
For better and for worse. It's not always kind of happy, and that's why we're there, so it's good. It's really good. And they're incredibly strong, resourceful, intelligent women who are just really stepping up to what can be a really tough process, and I think it's underappreciated. I really do.
As in what women go through when they're giving birth?
What women achieve.
Oh yeah, achieve. I love that actually, because it's an achievement, isn't it?
Yeah, 100%. Like, I was a miserable pregnant person.
Were you?
Oh my God, yeah. Oh my God. I was so sick. And so...
Did you have hyperemesis?
With my second, yeah.
Yeah, oh God.
But I slept better because I was absolutely stoned on all the anti-nausea and vomiting meds. So.
Oh yeah, okay. Zafran me up.
It was
mainline me
Caravan.
Zafran.
Yeah,
Caravan, of course. Yeah.
So I slept like a dream. But and then I got like postpartum thyroiditis and 2 emergency C-sections, and so
you were like textbook anaesthetist dream.
Stuff. They wheeled me in for my first emergency section. And I just remember like basically coming out with my entire medical history and quick smart, because have you done this a lot?
Okay.
Yeah. No.
Yeah, I know. Yeah.
But yeah, it was interesting being on the other side. And it's funny because if I talk to my patients now and I say, I've been where you are, they're like going, oh my God, I feel so much better knowing that, what I'm, and you're like, yeah, so this is what it's going to feel like. And this is how it's going to be. And you'll be fine, But yeah, I love the rotunda, and I don't know if you got the same from the other rotunda people you've talked to.
They love their jobs. Oh my goodness. Yeah. And they just...
We're like a little cult.
You absolutely are. Yeah. And I haven't had anyone on from... I had Jerry Agnew on from Hollow Street, and he loves his patients too. I think
He's a nice guy.
Yeah, he is. I think that there's definitely the sense that you're there for your patients and you do love what you do.
Yeah.
But tell me about epidurals and what they do, what they don't do, and there isn't as many mobile epidurals here as there is in the UK. That's a question that came in. I want to know why, and then why do epidurals fail? So maybe we talk a little bit about that.
Okay, so epidurals can be used in labour or not in labour. So they're actually used perioperatively as well for pain relief. So essentially what it is, you go to the dentist and you get that injection of local anaesthetic and you spend about 20 minutes sitting out in the waiting room like this and all the stuff that used to hurt doesn't hurt anymore. And an epidural is essentially like that, but it's more central. Okay, so it's down. What we do is we go in with an epidural needle. It's all done essentially by tactile feedback, essentially through the needle and the equipment that we have. We go through and between the little bones in the back, I know it sounds painful already. There's a little channel.
I'm squinting.
I know, you can see it. So there's a little channel that we find our way into. And if we're bang on midline and we're going through that, it's actually not that uncomfortable. It feels nearly just like a dull kind of pressure achy pain, like a little pressure ache.
Okay.
And I always ask patients, does that feel? And when it feels like that, I know that it's kind of within millimeters of exactly where I need it to be,
Okay.
So then we advance through, and when we hit this little potential space, between these two specific layers, which is the dura on the inside. Oops, sorry.
That's all right.
The dura on the inside. And then the ligament layers, which are the ligamentum flavum, which is more toward the outside of your back. We can feel a change in the resistance through the needle and through the feedback of the syringe on the needle. And we know that that's the epidural space.
So that's all done with you feeling your way in.
You feel your way in.
How many mannequins do you have to practice that on before you actually do it on a real person?
I'm not actually sure anymore. I'm not sure there's lots of tactile simulation models and stuff like that now.
And is the first time you do something like that, is it really nerve-wracking?
Well, you do spinals first.
Okay.
So you do spinals first, which is a different technique, but you just get used to finding your midline and finding your level and finding your space and giving appropriate levels of kind of local anesthetic into the skin. The skin is the most sensitive area, and then after that it's less sensitive.
Okay.
So you get used to doing that first. And the difference is that with the spinal, you're going in with a much smaller needle, but you're going in that little bit deeper through the dura into the fluid around the nerves, injecting your medication and coming straight back out.
Okay.
So it's a single shot in and out. With an epidural, you go in, you stop in front of the dura, and then you thread a tiny little catheter, teeny tiny little plastic tube, completely sterile, most important thing. And it's an inert material, so it doesn't react with anything in your body. And that's threaded into the epidural space. And then the needle comes out, catheter stays in, and you can run medication through that as long as you want.
How does it stay in this space?
We secure it at the skin.
Oh, okay.
Just stick it down.
Grand. And it just runs for as long as the labour lasts?
Like a little drip into your epidural
yeah.
space. And what we give you then is local anaesthetics plus or minus a little bit of opiates to make them work better.
The opiates are great, aren't they?
It's only very, very low dose. Yeah. It's tiny.
Is it a little bit of pethidine?
No, fentanyl.
Okay.
So tiny, like 2 mics per mil, and you're given 9 mils an hour, tiny amounts. Like if you were giving it intravenously, it barely would have an effect,
Okay.
You might notice it for a very short period of time. But over an hour, it's very, very little. But it just makes the pain relief a little bit more satisfactory. So then in terms of the pain relief and the local anesthetics, whether it's analgesia, which is pain relief, or anesthesia, which is numbness to a surgical degree, okay? So it depends. Like analgesia wouldn't cover you for surgical stimulus because it's much more challenging, okay? So anesthesia is what you need for surgical stimulus. It's like beer and whiskey.
Okay. Right. Okay, I get you.
Do you know what I mean?
Yeah.
So
which one are you saying is the
analgesia
epidural?
Is like the beer.
Okay,
yeah, it's the epidural for pain relief and labour. And you don't want really dense anesthesia for that because you need the feedback from your body. You need to feel some pressure.
Yeah.
you need to be able to move your legs. You don't want your muscles going asleep if at all possible. Because it takes away your ability to move around in the bed. It takes away your feedback, your ability to push sometimes to the same degree as
Can women move their legs when they have an epidural?
Should be able to, yeah.
So what is this mobile epidural then that people are speaking about?
So it's variable. There's lots of different concoctions that people could use for it. Some people just go in, and now we're into another thing again. There's a thing called a combined spinal epidural, where essentially you go into the epidural space. Before you thread the epidural catheter, you go in with a needle through your epidural needle. Okay. And that goes that little bit deeper, through the dura, and you can inject a little bit of medicine, come back out, and then thread your epidural needle. So you get a combination of the two. Yeah. Okay. So you could do a combined spinal epidural, give a little bit of fentanyl, which doesn't cause your legs to go heavier. Okay. Right. But will only last for maybe an hour. Okay. Okay. And then you thread your epidural and you can do your standard epidural. Or you could give a really, really, really low dose local anesthetic into the epidural space. Now, there's always some degree of muscle weakness. Right. Okay. So with a mobile epidural, there's always the risk that your muscles could get a little bit weak. Okay. A little bit of risk of fall or something like that. So you need somebody with you at all times, somebody who's able to check your motor block. You need to be able to do a fairly deep squat and stand up to ensure that you're able to support yourself against gravity, because gravity can be sneaky sometimes in the setting of local anesthetics. Okay, yeah. So in Ireland, it's about staffing a lot of the time. Okay, I was just going to get to it. Is it that's the reason sometimes,
why?
Yeah.
Okay. So are they done in Ireland, or is it just they're not? Like if someone asked for it, could they get it, or?
Again, it's down to staffing. Okay. And it's about having the right policy and education in place to ensure that, the person who's looking after you, the person who's looking after somebody with a walking epidural, has the required training to understand what motor weakness looks like, does the interval checks to ensure that they have enough power that they can walk, because you're getting this continuous feed that can slowly build up. Of local anesthetic. So it needs ongoing assessment at all times, So it's a tricky business. It's not completely straightforward.
It's labour intensive, to excuse the pun. Like it actually is very much. Yeah. I can see why you'd need someone there at all times. You need
portable pumps. You need, a lot of different things. You need portable feedback, because you've got somebody on a CTG as well, because they have an epidural. So there's a fetal heart monitor there that's there continuously. So you need to have a portable monitor. There's so many things there to keep you safe once you've opted for that. So it's not just a case of pop it in, she can move her legs, let her go.
Yeah, of course.
Yeah, I wish it was.
I know, yeah, that would be great.
Brilliant. Yeah.
And how many epidurals fail? When you give them, some people say they might only work down one side. That must be awful, having the pain down one side, not another. Yeah, so because epidurals are a little bit, they act a little bit more indirectly than the spinal. So the spinal goes directly into the fluid around the nerves. You give a much lower dose, you actually get a much denser block, potentially much faster onset. Okay, but it's only for a very limited duration of time. So that's not really going to work for labour, which is going to be who knows how long. Mm-hmm. So with an epidural, you're going in, you've got that dural membrane there. Mm-hmm. Okay, so in the epidural space, you have veins, you've got some fatty tissue, you've got some arteries, you've got nerves coming out of the spinal cord. And then some of the medication does go across the dura and diffuses across into the sac and acts more directly. So you've got a multitude of things going on in that space, okay? And also when we thread the catheter, we can't visually see exactly how it lies, okay? So that lies within a triangular space. It's very hard to hit the center of a triangular space. So we pop that catheter in. So then we give the medication, and we ideally want it to spread uniformly through all of those things. Oh yeah. And we can't always guarantee that it will. Yeah. If it lies very much over to one side, sometimes it may not have threaded directly into the epidural space. It might have gone paravertebral. Okay. Or maybe there's a little membrane within the little septum within the space we can't see.
There's lots of different reasons.
Okay. Yeah.
Maybe the epidural space, this particular. So what we try and do with the medication is essentially recruit lots of little channels to try and give you as much uniform spread as we can. But we can't always guarantee it. So sometimes, so what we've moved now toward is giving kind of a higher volume of low dose to try and give you good analgesia because you're not getting that high whiskey concentration. Okay.
Yeah.
But we're giving you good volume to try and recruit as much spread through the space and get as much uniform kind of spread and bathe the nerves as uniformly as possible.
Okay.
Okay. But we can't always see it. So I know generally about 4% of epidurals are recited if they're not going to work well.
Okay.
The other thing that we deal with is your pain, your sensation, I'd go with actually. Your sensation in labor comes from different elements. It's transmitted through different parts of your spinal cord depending on the stage of labor you're at. So earlier in labor comes from kind of higher up, say from like the lower thoracic and upper lumbar nerve roots. So that's what you need to be covered during that earlier stage of labor. And then during the second stage where the baby's moving down right through your pelvis, you need your sacral components covered because the tissues, that's what supplies the tissues then. So with an epidural, it takes a little while for it to sink down and cover those sacral nerves. So if you get an epidural and you bomb through your labor, which is wonderful, you might find that you feel a lot of the perineal discomfort at the time of delivery because the epidural hasn't had time to cover those nerves yet. It takes an hour or two to completely cover them.
And then why aren't women given an epidural? Question come in at 1 centimeter. Why do they generally wait until they're
Policies.
6, 7, 8?
It can be policies in the hospital. It can be.
What's the reasoning behind the policy?
Sometimes it's staffing. Sometimes it's just resource allocation. There's always, sometimes, again, some people prefer to keep mobile. In an ideal world, again, now this is obstetrics and midwifery, so we might actually defer to them to a degree. Okay.
That's fine. I know.
But ideally,
we're obviously going to get into this conversation.
It is an ideal aspiration that people keep mobile as long as possible in their labor for a lot of different reasons. But it's down to choice as well for a woman. So, if you've got somebody who's at 4 or 5 centimeters and bombing through her labor and in a lot of pain, and you've got somebody who's at 1 centimeter and really the head is high and she just needs to keep moving. Again, it's not that one person will be chosen over another. It depends on the policies within the institution. We don't make those calls, so I can't really comment on them too much. And I've already probably commented on things that I shouldn't. But it's variable. There's a million different reasons.
Okay.
It's not going to impact things analgesia-wise to a degree. And I've given epidurals to people very, very early in labor for a variety of different reasons.
Yeah.
I don't personally believe there's ever a too late a time either, unless you're actually crowning.
Okay. Fair enough. Said like a true anaesthetist.
Well, yeah, there's lots of options that can be quick, ideally, in terms of providing you with pain relief. But obviously, if you're actually at the bearing down stage and the head is coming out, I think you've probably missed the boat there.
Yeah, you've done the work.
It'll be quicker to have the baby than actually go through the risk of having a procedure done that involves somebody putting a needle in your back, And
can I just ask you your thoughts on, so say a lot of women would aspire to give birth without drugs naturally. Yeah. Or, I think that word naturally is wrong because I think
unmedicated.
Yes, unmedicated, because obviously, so that's what most women would love. That's their ideal. And then when they go into hospital and they feel the intense pain that is labor, they get an epidural and then they almost feel like a failure because there may or may not have been instruments used or whatever. Like, what do you say to those women? Because I think that it's, I hate to think of women feeling that they're failures themselves because they ended up with C-sections or ended up with
I don't think anyone,
or forceps or whatever it was, or an epidural.
I don't think anyone should get to kind of invalidate a birth experience.
Yeah.
And I feel really strongly about that. Every labor is different. Every labor is different in the same person. You could go through labor 5 times in your life and it could be 5 different kinds of labor. Every pregnancy is different. You're older, you're younger. The baby is a different baby. You know, it's just all very different. I have a friend who had 2 very easy births. And on her 3rd delivery, she actually had 3 babies without epidurals, but she goes like she was basically giving birth. Thankfully, by the time she was kind of going, no, I actually need the epidural this time, because it was just very different. The baby was in a different position.
I have a friend like that who ended up with a C-section. So she had 2 vaginal deliveries initially, and then her 3rd baby was a C-section.
Like it's just, there's so much that we don't have a say in as individuals or as medical practitioners, you know, and we live in a world of options, and it's great. And in the same way as nobody can tell you that you can't have an epidural, I don't think anybody should tell you should have an epidural. You know, I think every woman needs to be told, these are your options. You know, there are medical situations where it is advisable medically that you should consider some epidural pain relief, like say if you've got preeclampsia and uncontrolled blood pressure and you're in labour, and it will put you at risk, because the epidural really helps you control your blood pressure in that situation. You know, those stress hormone surges, it can help level them out and really help in terms of keeping you safe.
Yeah.
Somebody with epilepsy, I would recommend that they would consider some pain relief like that, because it enables them again to get some rest. It decreases kind of the hyperventilation associated with contractions that can actually lower their seizure threshold. You know, there's so many things.
Okay.
So, but at the same time, do I go into a room and I say you have to have an epidural? Absolutely not.
Yeah.
You know?
And what are your thoughts on the free birthing movement then?
These are women who are making their own independent decisions. I do think that in an ideal world, everybody should, yes, be able to make their own decisions, but have timely access to emergency care if they need it.
Yeah.
And that's not always possible. So I think you have to be able to make your decision in that context.
With a full understanding as to the, you know, the pros and the cons of whatever you decide to do. If
you decide to give birth somewhere far from emergency services or easy access to emergency care, and something goes wrong with you or the baby, you know, if you've consciously made that decision in that context, then that's fine. That's the decision that you've made, you know, but it is your decision, and the consequences would be that person's consequences to own, you know?
Yeah.
So I think in an ideal world, we'd have really good infrastructure where people could give birth wherever they wanted.
Yes. And have an emergency team on tap.
Yeah,
whenever
that'd be wonderful. And I would say absolutely give birth wherever you want in that context. I do have my own bias though, because I'm part of the emergency team who comes to kind of deal with some emergencies. Yeah. So I think, you know, I accept that bias.
Yeah.
You know?
I know. And I think that working in a hospital where you're called upon when there are emergencies makes it difficult to...
Yeah.
Because obviously you've seen the emergencies. Yeah. When I told, you know, my brother's a doctor, and when I told him I wanted natural deliveries and to do it that way with no drugs, the first thing he said to me is, he said, that's like going to a dentist to get your tooth extracted without getting a local anaesthetic. Are you mad?
It's not though.
So, but that was his, I know
delivering
that.
Somebody is the physiological process that you're designed for.
Exactly. But, you know, so I think though there are different levels of what you would feel comfortable with as well and like that, I think women should have the choice that they want to have, but without, and you don't want to be being made out to be a fearmonger either, but there are consequences to home births or free birthing or whatever if there isn't a medical team around 100%. You to mind you.
Absolutely. And like, but that doesn't mean it's going to happen either.
No.
And I think, you know, if people choose to deliver away from the possibility of that emergency care, that kind of expedited emergency care, that's their decision, you know. I don't really.
No, I hear that's fine. I think we've discussed that now.
Yeah.
I just wanted to put it out there because I got a few questions in about that. Obviously.
Sure.
So have you? So sometimes a pregnant woman will have to be put under general anaesthetic. What are the circumstances that causes that to happen?
So lots of different things, to be honest.
Okay.
Are you talking about the entire peripartum experience, or is this purely for delivery?
Let's go purely delivery initially and see how that goes.
Okay, so there are situations where the risk of, even in an elective situation, where the risk of general anesthetic would be deemed to be lower than the risk of a spinal or epidural.
Okay.
So in patients who have, say, a bleeding disorder.
Okay.
Because what we don't want is to cause bleeding within, like adjacent to our spinal cord.
Yeah.
That then accumulates and puts pressure on nerve tissue.
Okay.
Or people with like really low platelets, or people who are like on kind of high dose heparin and come in for an emergency delivery or something, So in those situations, a general anesthetic may be the safer option for that individual. The other one would be potentially it may, depending on the circumstances, be quicker to anesthetize the mum for an emergency cesarean section by general anesthetic instead of spinal anesthetic. So it would be done for the health of the baby. Say if there was an abruption or the baby had a very low heart rate.
Okay.
And so in order to like expedite access to the baby,
yes,
we might go down a general anesthetic route with the mum.
And is that difficult on the mum because she's knocked out?
Fast. It's fast.
Okay.
It is fast. And I always say it can be quite utilitarian. I go up, I introduce myself, I take a very brief history of things that I need to know to provide a safe anesthetic. And then we have a quick chat about general anesthesia and it's sleeping time. And then generally we will always go back. And I always say, like, we try and finesse it retrospectively. We always go back and kind of talk about the context of those decisions.
Okay.
Now, if she says, I really don't want to go asleep, nobody's going to assault anybody with the general anesthetic, but generally mums will just be like, yeah, I understand, because they already know.
Yeah, okay.
They already know that something is happening that needs to be fixed fairly quickly.
I'd say it's difficult enough for women to go through that, though, because they have a bump.
It is.
They go to sleep and then they have a baby and they might wake up, they don't have the baby with them or whatever. Like I'd say there's a lot of...
It's a lot.
To process.
Yeah, it's a lot.
Yeah.
It is a lot. And there can be a series of debriefs,
Okay.
And I think it's really important that women have access to that.
Yeah.
Because sometimes the questions only kind of come to them a few weeks later when they've had time to process it.
Yeah.
And that's important.
And do you feel that there's good follow-up care for women that are dealing with a traumatic birth or, stressful situations?
I think it's evolving. It's always evolving.
Yeah.
It's always evolving. It wasn't too long ago that kind of people were just like, I really just don't want to know about it. And now people are like, no, I actually need to understand kind of why we had to go down that route. And like, it will be a quick like history, airway exam, and then kind of a discussion briefly regarding like, X, Y, and Z is the reason why I do think it would be safer to go with sleep.
Mm-hmm.
Do you understand? And are you okay with that kind of thing? Very, very quickly. But you're talking, like, I think one time we had somebody come into the emergency department, a C-section was called, and she was asleep with baby out within, like, you're talking like minutes.
Oh my goodness.
Yeah, it's very quick sometimes.
Okay. And then what do you do out in the matter then? Is that... We're going to flip.
Different. Whatever they put in front of me.
Okay.
So
Are you half time each place or are you more time in the rotunda?
More time in the rotunda,
okay.
Yeah. So it is kind of important, I think, to keep your hand in with everything.
Yeah.
In terms of lots of different populations, lots of different surgeries, lots of clinical pathway building, lots of subspecialty chats, lots of, that kind of way.
Of course.
So sometimes I do orthopedics, sometimes I do ENT, sometimes, like anesthesia for these surgeries.
Yeah.
And it's different, you know.
Oh my God, you do orthopedics and ENT too. You are just so talented.
Anesthetics, so we talked about the list. Yeah. So ENT list, orthopedics, urology.
Do you think you could have a good old stab at a surgery now? You've seen so many C-sections. Could you just do one, no?
No, that'd like me handing the obstetrician the epidural needle and going, sure, have a crack.
Okay.
I don't think either of us want to cross the drape in that way. I'd assist. I'd like to assist probably again. I haven't done like assisted in a very long time.
Okay.
And I think, you know, a Freaky Friday cross the drapes and assist might actually really be good in terms of team building.
Yeah.
Because there's so much that it took me a good while to understand in terms of what they find tricky and what we find tricky, you know?
But it's so funny because even you're talking about putting the epidural into that space and you can feel and it's tactile response. That's the same with the surgeon cutting into flesh. To
a degree, yeah. And some surgeries more than others, yeah. Some surgeries are done with a lot of tactile kind of feedback, yeah.
It's just, it is mad. And because you know the way some people think like a doctor is a doctor.
Yeah, no.
But it's absolutely not. It's all that training and the subspecialties is so important, isn't it?
Yeah. And that's why I think it's really important that I have my matter practice as well. You know, different patient populations, different backs, different airways, different surgical considerations, because obviously the anesthetic considerations for an ENT surgery is actually quite different to the anesthetic considerations for a urology surgery. And even within urology, like the anesthetic considerations for kidney stone surgery versus like a nephrectomy where they take your kidney out. Yeah. Or like, you know what I mean? Like it's all very different.
Okay.
You know, there's some principles that remain the same, but the plan is slightly different and what the surgeon needs is slightly different.
Okay.
You know?
And how long does the general anesthetic last in someone's body?
Oh yeah, that was a question. Functionally until you wake up.
Yeah.
Okay. Yeah. But like, it's the same with any drug elimination. And you know, this as a pharmacist, like you're talking half-lives and all this kind of stuff. So depending on the drug you give, you know, people
but it
will
isn't a case that it's lingering for, you know, months afterwards.
Shouldn't be, no. Yeah. Now, in theory, you know, when you've got a washout curve, does it ever hit zero? Yeah, you know, but not really, no. Okay. So it doesn't hang around for ages and ages and ages. What can happen is that like you're very groggy that evening. It can take a day or two to recover from it. In terms of insurance and driving and operating heavy machinery and stuff like that, insurance companies are getting more and more conservative with that now, in the UK. Yeah. Okay. Before it used to be like you can't really drive for 24 hours. But I would say to somebody, if they're having major surgery and they're planning to be out and about and driving in the next kind of 48 hours, I double check with your insurance company. Okay. Yeah, because they are starting to extend that in the UK now. So just double check. Be careful. And if you're in any way not 100%, do it.
And if you have to have a number of surgeries in a year, is going under general anaesthetic multiple times?
Tolerance, is it?
Do you develop a tolerance or is it dangerous? You know, apart from the fact that you're going under general anaesthetic and there's a risk involved there in the first instance?
No.
Okay.
Shouldn't be, no. Like the only thing I'd say to you in terms of if you're having multiple anesthetics during a year, it's more to do with the underlying disease process that's requiring you to have multiple anesthetics during a year. You know, if you're having multiple anesthetics because you've got a significant bowel issue and you're becoming progressively more malnourished because of that underlying bowel issue, then your recovery is going to be compromised. Now, it's not necessarily your anesthetic risk per se, it's your perioperative risk.
Yeah, okay.
You know, so it's different. But the anesthetic itself is fine.
Okay. I did have a question in from a lady who said that she was told that because of her BMI, she had to have a chat with her anaesthetist prior to her epidural. Could you maybe explain the reason for that?
So this is a little bit of a sensitive subject, understandably, for people. And we see a lot of it nowadays. So the way I kind of tackle it is, as a general rule, I think most people are unhappy with some element of themselves in terms of their weight or distribution or something.
Yeah.
Okay. And there's a lot of societal value put on that.
Mm-hmm.
But I think that when, like, especially in the Western world, a lot of people, and I move toward the word kind of overnourished rather than obese or anything else. And I think that is what it is, actually. You know, we've a lot of very easy access to food, and there's a lot of eating behaviors that are different than how they would have been a long time ago, when maybe when food wasn't as easily accessible. Mm-hmm. And that's a separate issue.
Yeah.
Okay. So, but I think that if the distribution of fat within your body impacts your medical care, we need to have a medical conversation about it.
Okay.
Okay. So I get lots of people coming through who would have BMIs and this of X number. Okay.
Yeah.
And a lot of it in terms of anesthetic risk has to do with the distribution of it. Okay.
Okay.
So if you get somebody who has a lot of fat up around their jaw or something like that, or around their airway and stuff, it makes it a little bit more difficult to kind of give them a little bit of mask support when they're going asleep and things like that. It can make it a little bit more difficult in terms of airway management as they go asleep. Okay. And in the same way, somebody who's very, very pear-shaped, okay, it can make it a little bit more difficult in terms of finding the right spot to start. I keep hitting the mic, finding the right spot.
She's fighting with the mic.
I know, clearly. But finding the right spot to start with the epidural siting process.
Okay.
Okay. So that can be a little bit difficult. It can take a little bit more time. As people carry more fatty tissue as well, their veins become deeper. So there's a whole sequence of events with somebody who's on the bigger side. And I mean, like, we are seeing people coming through now with BMIs in the 50s and 60s. Okay. And what it does is it adds time and a little bit of complexity to their anesthetic care. Okay. So placing an IV can be more difficult, and we need IVs because that's how we administer our drugs in terms of keeping you safe.
Yeah.
Okay. We always do an airway assessment because anaesthetists are paranoid. So even if we're doing an epidural, we assume we have to get near somebody's airway at some stage, just in case.
Yeah.
Okay,
it's all this cross-check thing.
Yeah,
you do. Yeah. Okay.
Yeah. We check everything. Okay, so the airway can be a little more difficult. Positioning can be more difficult for surgery. Surgery will take longer. So we like to have the time to site a really good working epidural, because it will take a little bit longer. B, an emergency spinal will take a little bit longer. Yeah. So to have a good working epidural that we can then give you the whiskey strength, local anesthetic instead of the beer we were giving you earlier on, makes a big difference in terms of getting you access to good emergency care. Okay. So, but again, it's not absolute numbers, it's distribution of fat, you know. It's not just as cut and dried as a number, X number BMI makes it difficult.
Yeah. And it's also nuanced as well.
Yeah.
And it's not negative towards the patient who has the higher BMI.
No,
it's
not
basically
at all.
about the management of them in the safest way possible.
It's about informing people about like, if I got somebody through wildly uncontrolled blood pressure, okay, I would want to sit them down and talk to them about the impact that will have on their medical care. Okay. Mm-hmm. If I got somebody through who had a difficult airway, I'd want to sit down and talk to them about the impact that will have on their medical care. Mm-hmm. And it's the exact same for this. Okay. And it's not done as a value judgment. Mm-hmm. And that's why I mentioned that originally, because I think that we really have to not conflate the two things.
Yeah.
It's about providing information to an individual who can then make good, nuanced, individualized decisions regarding the kind of care that they will receive during their labour and delivery that will give them the best outcome.
Okay. And it's not a case of someone can't get an epidural because they live in a bigger body or have a higher BMI.
No.
Is that the case? They can. It's just
in fact, we'd love them to.
Okay. Yeah. Okay.
So it's one of the kind of medical things that I'd say you might think about it, because it might it might improve your anaesthetic care. Because what you don't want is for the baby to be in trouble and then there to be kind of difficulty getting IV access, difficulty getting a spinal in, difficulty positioning for an airway for it to go asleep if we can't get a spinal in.
Okay.
It just, the complexity and the time increases. So we like to preempt that by having that chat up front, getting all those things done really early so that we know they're there.
Yeah.
And then if we don't need them, excellent.
Okay. Yeah, fair enough. I know this isn't necessarily your area of speciality, but I'd love to talk to you about pain management. And I know you spoke briefly there, you do deal with acute pain management, and chronic pain is more a subspecialty again. Yeah. But we do have an issue with pain management in this country in general, in terms of pain clinics and access to care and that, and the whole, there's a debate going on about whether or not codeine should be over the counter or should be prescribed or anything like that. Like, what are your thoughts on, I suppose, chronic pain management and the medicines that people are given for that? And should there be more care? Should there be more clinics around? Should there be more consultants? Is there?
Oh, of course. Yeah.
Goes without saying.
Yeah, pretty much. I don't have the numbers to hand in terms of what our numbers should be.
Yeah.
But I know we don't have enough.
Yeah.
And acute pain and chronic pain are two different things.
Yeah.
They're not mutually exclusive, but they are two different things. And pain can be a terrible life-defining thing, and it can be something that defines you as an individual when that's not how you used to be.
Yeah, when you say that, it is so true, because we'd see it a lot in practice too, people that are living with chronic pain
and it's not even access to the analgesia, it's access to the biopsychosocial support stuff.
Yeah.
The psychology of living with it, and definitely I think everybody needs access to that. And, we're all living longer. We're going to have chronic pain.
Yeah.
So, sorry. So I like, it's not my area of kind of subspecialty practice or anything, but I think
I know
any GP would tell you the same thing.
But even when you say that, it's the access to all the other care that goes with it. It's so important, and it can make such a difference to people's lives. But I would have seen many people, and even, get messaged all the time about people that are in chronic pain and the effect that it has in their life, because some people can't work with it. So obviously they're financially insecure then. Yeah. It can cause serious mood issues.
And nobody wants to be suffering.
No.
If everybody could be living their best life, that'd be amazing, you know? But so it can define your day-to-day existence and your year-to-year existence. And that's a really hard thing,
Yeah.
So I don't, there's lots of pain specialists around, but we need more. And I think, access to good and timely pain specialist support would potentially help with the other issues like codeine addiction and stuff like that, because people wouldn't be accessing them.
Yeah. Yeah. No, I agree. Can I ask you a little bit more personal?
Yeah, go for it.
First of all, where did you grow up? Did you always want to be a doctor? What was your family life like?
Okay, so I grew up in Ballina, County Mayo. I'm one of 6 kids, 4 girls and 2 boys. And my dad was a businessman. He had a shop in town, and my mum was a teacher before she got married, national school teacher. And when I was in senior infants, I told my senior infants teacher I was going to be a doctor. Okay. And then I spent many years telling myself I didn't want to be a doctor because it sounded like way too much work, to be honest, And then I finally kind of admitted and committed, I suppose. Yeah. To getting the points and the points race and the bits and bobs,
Okay. And you seem like as if you love your job.
I do, yeah. Yeah, I do. I love my job.
And are there any other doctors in the family or?
Well, my sister is an anaesthetist. Well, I should say intensivist now. She's primarily in intensive care with some anesthesia, but she went through anesthetics as well. It was my idea first.
I was going to say whose idea was it? Because usually it's one follows another. Is that right? So your idea. So you're not competitive at all there, Anne,
no,
are
not
you?
at all. Never. No, no. And I love telling people that it was my idea first. And I always say I'm the nice one. And she always says she's the normal one.
Okay.
And I'm like, really?
My sister and I have that bit of banter too. I don't know.
Yeah.
I don't think either of us are considered normal. I don't know if you saw our antics the weekend.
I don't think either of us are considered nice.
She was dressed as probably not. No, Rachel's definitely considered nice. Rachel and I used to work in the same pharmacy
really?
company, and people would say to me when they realised she was my sister, oh my God, your sister's just so nice. And I always took that as, does that mean you think I'm a bit of a bitch?
Yeah.
Like, no, you're just so much of a messer.
Yeah. Well, yeah, Margaret's tougher than me, I think, in some ways.
Okay. Well,
Yeah.
Rachel happily dressed up as a Volvo for the Women's Merry Marathon at the weekend.
Fair play to her.
So
Fair play to her.
she took one for the team that day.
I can't see Margaret dressing up as a Volvo. I could ask her though.
And obviously life with a man like Afif is just dreamy, is it? Do you get that? Do you get that? Because you know the whole thing about a man with a baby is considered to be so, women just love that. Yeah, he saves the baby. So people will fawn over him anyway. And then he's also an artist. So.
Yeah. Yeah.
Do you bring him down to earth, Anne?
Yeah, I see. I don't buy into that brand.
Okay. Clearly why he married you.
Clearly, yeah. Oh no, look, he's a nice guy. Clearly, I must think he's a nice guy. I married him.
Yeah.
But yeah, it's funny. Like there's work Afif, you see, as well. So I know work Afif as well as home Afif, as well as artist Afif, and as well as like Mr. Podcast Afif. Like,
I know he's really steaming along with podcasts
he
now,
is,
isn't he?
So yeah, I just. Yeah, there's lots of different Afifs.
See, he said like a true wife, isn't that right?
Yeah, there's lots of different Afifs. Like.
Did you meet in medical school?
So he was we graduated the same year, but he went to Trinity and I went to UCD.
Okay.
So that was the big
rivalry.
Divide. Yeah, the big divide. So then I did my medical scheme that I did medicine before anesthesia. So I did that in James's. So there's lots of Trinity graduates there.
Mm-hmm.
So then he was at one of the work parties because he was working in Crumlin at the time doing pediatrics. So
okay.
Yeah, so that's where we met.
Okay.
Yeah. He asked me for my number and I said no.
I love it. Yeah. I actually do know the story. I'm just asking you because I think it's fun. I think he asked you a number of times for your number and you said no. We'll leave it there. Anne is not easy.
No, it's just the final bottle of wine that got me there. It was a very long night.
Oh my goodness. Is there anything else that you'd like anyone out there listening to the conversation that we had to know about anesthesia or to know about what happens when people go through surgery or epidurals? Or are you ready for my two banger questions?
What would I say to people?
Tried to cover it all. I think I covered all the questions. I was flicking through them there. Actually, do you know what? Something that I did miss was, people that react badly to anesthetics. So my mum would be a prime example. She just wakes up vomiting almost as this type.
Like there's some, like when we talk about bad reactions to anesthetics, like the anaesthetist in their brain thinks like malignant hyperthermia and
because I saw your face there.
Yeah, just these genetic like familial susceptibilities and stuff like that are quite rare. Aside from those, some people can get bad post-op nausea and vomiting. Some people can get a lot of shivering and shaking. So the post-op nausea and vomiting, I would count myself as a bit of a puker in life, absolutely. Quite a sensitive vomiting center, and nausea and vomiting center. And it's just there's some of the medications that we give can trigger that in some susceptible people. And like the risk factors as an individual would be like if you get motion sickness, if you tend to kind of feel nauseated quite easily, if you're young, female, non-smoker,
Non-smoker?
Yeah.
Okay.
Yeah. And then in terms of the surgeries that are more, as we'd say, emetogenic. So middle ear surgeries, inner ear surgeries, eye surgeries, gynae surgeries, laparoscopies, those kind of things would be a little bit more nausea inducing as well.
Can I ask you why someone that doesn't smoke
I think it's just
has less nausea? Is it to do with
I think it's just they're more sensitive to triggers.
Okay.
There you go.
Okay, interesting.
Not that I think people should take up smoking so they don't feel sick. That's not what I'm saying.
I wasn't going to suggest that. That's going to be in the reel now.
I know. Anne
says take up smoking because you won't get sick after your anaesthetic.
But yeah, there are don't. But and then so like there's people who are sensitive to the anaesthetic itself as being emetogenic, especially like with the vapor that we use. So after we put people to sleep, sometimes we use the IV stuff to go asleep, and then sometimes we use a vapor that you'd breathe in and out while you're asleep to actually keep you asleep. It's not the IV stuff that keeps you asleep.
And that isn't the same as the gas and air that you get in...
No.
Okay.
But gas and air can sometimes be nauseating as well.
Oh no,
it can be quite nauseating. Some people find it very nauseating, yeah.
I find it fantastic.
Yeah.
In fact, if you could hook me up with some now, I'd appreciate it.
Well, I don't have my car. Can you identify someone in my car?
Oh, great.
You'd be my God, I'd be so popular.
I was going to say, you'd be literally the party woman of the century. Can you
just
imagine?
like reversing there, Anne.
It's fantastic. It's fantastic. I think there's laws probably against you having one of those.
Entirely, like the medical council. Yeah.
You'd be gone.
I've got way better drugs than that anyway at work. So to be honest.
Oh, I love it. Well, listen, I'll one up you the drugs. I have all the drugs.
You have all the drugs. You've got the.
I've got the key to the safe.
The pharmacy is the only place at work that my swipe doesn't let me in.
Okay.
Isn't that so funny?
I know, yeah.
It's so funny. Like myself and one of my colleagues, Roshan, used to always laugh about it. It's
the gatekeepers.
Do not let the anaesthetists into the pharmacy.
No.
Just don't.
It's just not allowed. They'll just like run rampage on it.
So we do love our pharmacology.
Yeah.
But in terms of, so there's, if you kind of are having a surgery, let your anaesthetist know that you get post-op nausea and vomiting. They can then try and tailor your anaesthetic to it. So you can get like 2, if not 3 or 4 anti-nausea and vomiting medications prophylactically before you start to get sick. The other thing that's becoming more and more kind of prevalent and popular is to not use the vapor as patients where possible and use total intravenous anesthesia. Propofol itself is a mild antiemetic, actually.
Yeah.
So you kind of avoid the trigger while giving an antiemetic.
Okay.
So that can be discussed. Now, it's not necessarily possible all the time, depending on the situation, but it's certainly something that could be discussed. And then in terms of the shivering and shaking after surgeries, so about 1/3 of people can get this. It's like a non-thermoregulatory shivering after an anesthetic. And so it's not related to necessarily being cold in terms of your core temperature or anything. It's more to do with the redistribution of blood flow under anesthesia and a resetting of your shivering threshold.
Okay.
So people feel like, I'm going into shock. You're not. It's just really annoying and uncomfortable. And it does settle down, but it's sometimes actually a response to pain and the surgical stimulus as well, So there's a few different ways to combat it, none of which are completely and utterly 100%.
Okay. Well, that's reassuring.
Reassuring,
Thank you.
yeah, 100%. So just cutaneous warming, so get the bear hugger on it, that kind of inflatable warm duvet that we use. And then things sometimes ondansetron, clonidine, give those ones, but they're not great. The best one actually is a very low dose of pethidine. Okay. Now, I don't love pethidine though, because it triggers the nausea and vomiting that we just talked about.
Yeah.
So it's pick your poison, you know. Often if you just wait and get them with the bear hugger and warm them up on their skin, it will actually reset that.
Okay. Can I ask you one little thing about epidurals, just to circle back there before we finish? How do you make sure an epidural doesn't actually cause permanent back damage or pain? Because when they're bearing down and pushing, they can't feel what they're doing and they can sometimes, put themselves out. How is that negotiated?
So ideally, when we're using the lower concentrations, okay, it takes away what I like to call kind of that really gripping pain, okay, but you maintain the sensation of pressure, and that's an ideal world where you can move your legs. You still have control of your body. The worst of the pain, the pure kind of pain is gone, but you still have that intense pressure, and it can be really intense as the baby moves through the pelvis. So you maintain some sensations of pressure. Now, you won't necessarily maintain the same awareness of difficulty with positioning and stuff like that, you know, but there's actually no difference in incidence of back pain between women who do get an epidural and women who don't get an epidural for labor.
Okay.
Yeah, there was like, I think hundreds of thousands studied in North America over the years, and there's no difference. It's having them children.
Oh yeah. And carrying them around their hips for, you know, until they're 1 and 2.
Yeah.
I actually had to stop on my 3rd. I made a conscious effort once he was able to walk to stop lifting him because I knew I was at the precipice of doing my back. I could feel it.
So asymmetrical.
Yeah.
I remember going to yoga for the first time after having a baby. And I stood on one leg and fell over immediately because everything was just so.
You're just totally out of joint. And then completely. I'm on my feet all day like you are. So so I knew, and I'd seen so many women coming in to the pharmacy with pain, you know, on lots of painkillers or needing, you know, lots of physio because of this. So, and it's lugging them around as well, isn't it?
There's a lot of wear and tear that you kind of go through.
And even those baby carriers, like the ones that are fully on the front or the ones that are slingy.
Bad breastfeeding postures, holding the baby for a long time. And some babies just want to be held all the time. Yeah. You know, it's hard. Yeah. But so I do try and reassure people that there's no difference in the incidence of chronic back pain associated with it, whether you have an epidural or not. You know, because, and then we're back to, again, like, I think we minimize what a woman achieves and goes through, growing an entirely new person and then expelling them from her body. Yes. You know, it's, you know, it's pretty amazing. It really, really is.
My goodness! On that note, that makes it a lovely way to end that, doesn't it? But you're so right, and the miracle of it all the time, and you get to see that every day. I must say, I love birthing stories and all the rest. And actually, my For You page is all bloody newborn babies, and yes, mad how. So obviously, the powers that be know what I like, the kind of stuff that I like to see. They really do, don't they? It's mad. Yeah. So Anne, my 2 questions that I ask every guest is, what advice would you give to young people today first? It's kind of twofold, I suppose. The first thing is that things are never as permanent as you think they are. So the good times will go, but the bad times will go too. And it'll get better. And I don't have a lot of patience in life. And it took me a long time to learn to kind of hold back a little bit and to just let things settle. You don't actually need an answer all the time. Things will pass. The good times will pass. The bad times will pass. Time will continue. You'll continue, you know, and not to jump into things with 2 feet. Just bide your time. Let things level off. You know, enjoy the good times. Understand that the bad times will go. And you'll be back to good times again. But just, let it flow, kind of. I like that. Yeah. Let it flow. Yeah, pretty much. And then, what is the meaning of life? Yeah, you texted me that this morning, and I was like, I'm so sorry. See, I thought you would have known. Okay. I thought you would have known. I know. I'll blame Afif. Sugar. I'll blame Afif. He should have told me. I know. He should. He should have. He deliberately didn't. The devil. I was thinking about this on the way up, actually. And it's going to sound so trite, but I really, it's kind of how I see things. So in my job, I see a lot of really, really good things, okay? But I also see families going through the really, really awful things, okay? And I think people, in some ways, choose not to talk about the really awful sides of maternity and the really hard sides of maternity, because it's really
like unpleasant, you know. And there's families in making very difficult decisions, navigating very, very grey areas, you know. And I think that when I see them making decisions, and sometimes they're making decisions where the medics are saying, okay, medically, this is what we would advise you. And they're saying, no, you know, and I respect that. And it can be frustrating because you just see where they're watching the risk calculator accumulate numbers, you know. Yeah. But you have to understand that all of these things and all of these difficult decisions, and it's true for everyone, all of these decisions come from a place of love. And when you really disagree with what somebody is deciding on these huge kind of life topics, it's all coming from a place of love. And they either, like a woman who adores this baby, you know, and is making really difficult decisions that may be putting her own health at risk or the baby's health at risk on the hope that she can beat the odds or something like that. Yeah. That comes from a place of love, you know. Equally, somebody making decisions because they want the positive regard of somebody they love, you know, like everything, all of the hardness and the difficult things in life, it comes from a place of love. And I just think that we probably need to remember that and be a little bit more compassionate when people are doing things that you don't agree with, especially big decisions, because it is actually coming from a place of love. That's all.
That's lovely.
Is it though? Is it right though? It's a bit silly. I was trying to put words on it.
No, it doesn't. It's lovely because everybody has given me a different answer.
Oh, really?
Yeah. And I just find it really interesting how people just think differently. But like what you say, it's always a positive thought. Like no one's ever come on and said the meaning of life is nothing, you know.
42. But
so no, I do like that. And it's like only you could give that interpretation because of what you see and do every day. So I think that it's lovely. And
the hardest person to be in the room with, who might be acting out left, right and centre, it's probably because they need love or they need something that they can't, you know what I mean? Yeah. So it all just comes down to that. And it has been an absolute pleasure. Dr. Anne Doherty, thank you so much for joining me today.